In this video, a multidisciplinary team from the Providence Cancer Institute in Portland, Oregon discusses the importance of an evidence-based lung cancer screening program. What research motivated your team to develop a lung cancer screening program?
Lung cancer is the #1 cancer killer worldwide, as well as in the United States. And we realized, as many people did, that the institution of lung cancer screening can help to be a significant game changer. And so our program was very motivated to help participate in lung cancer screening and create our program here to institute a multidisciplinary approach to lung cancer screening, similar to that was designed for the NLST. In 2011, the National Lung Cancer Screening Trial published its results that demonstrated a 20% reduction in mortality with lung cancer screening in high-risk populations. And that was tremendous because it was a major impact in survival. In our opinion, if we can find lung cancer at an earlier stage and improve outcomes, then we have really helped a lot of patients.
So in my opinion, there was a lot of interest in lung cancer screening because 5-year survival rates for advanced lung cancer were so low. I think all of us who had worked in thoracic oncology felt there had to be some other avenue to try to find patients who could be more successfully treated, and those would be ones with early stage cancers.
How did your lung cancer screening program begin, and how has it evolved?
We used the data that was generated about lung cancer screening in order to execute the program. We had been interested in lung cancer screening with the publication of the International Early Lung Cancer Action Project, ILCAP, in 1999. We already had a vibrant thoracic oncology program at that point, and so we convened all the different stakeholders in the early 2000s, that being all the different members of the multidisciplinary team, so medical oncology, radiation oncology, thoracic surgery, pulmonology, radiology, and also primary care, as well as the health plan. Actually, our system has a health plan associated with it, to say, should we do lung cancer screening with the population of ILCAP? Remember, ILCAP was not a prospective randomized study. It was an observational study, but it had some intriguing aspects to it with regard to this was the first time where it looked like lung cancer screening might be successful. And so when the NLST got published in 2011, we already had all the people who had been previously engaged for about 10 years to say, shall we do lung cancer screening? So immediately upon the publication of the NLST, we could implement the program.
As the program has gone on, we've continued to use all evidence-based criteria. So patients are screened based on the patients who were involved in NLST. We've continued to keep track of the data of all the patients enrolled. We've monitored for adverse effects, complications, nodules, follow-up, deaths, to make sure that we were appropriately treating these patients and providing the best possible screening program we could.
What factors into your eligibility criteria for a lung cancer screening program?
Well, we didn't consider any. We just adopted those which had been validated or nationally accepted. This is not an insignificant problem because there's lots of risk factors that go into lung cancer that aren't well captured by this. So African Americans are at greater risk of lung cancer, and they also have a worse prognosis, and nobody really understands that. So that's a population that you would like particularly to be involved in screening, because screening provides stage shift, which provides therapeutic opportunity. That's the whole reason for screening, is stage shift in more treatable disease.
The initial NLST guidelines, they scanned patients between the ages of 55 and 74, and they used a 30-pack year smoking history as the eligibility for smoking history. Then USPSTF recommended 55 to 80 for the age, but also 30-pack year smoking history. But then CMS came out and kind of split the difference and said, well, we'll reimburse for patients between the ages of 55 and 77. And so, now with the latest USPSTF final recommendation, we're still going to need to wait for CMS to see what they say.
When our multi-specialty team discussed how we wanted to structure our lung cancer screening program, we intentionally designed it to match the criteria for the NLST. With the publication of the Nelson trial, then one of the issues discussed has been whether to incorporate a wider age in terms of screening, including those patients who are 50 years or older. The thing that one has to be careful with anytime we consider lung cancer screening or consider procedures being done to a patient, as our team had discussed and considered carefully, is that there can always be potential for harm. And then one needs to always balance out that risk and benefit ratio to most appropriately provide a service to patients. So the goals with our screening program have been to look at and include those patients who were at greatest risk of developing lung cancer, but who also had the greatest potential benefit, and then try to find lung cancer at the earliest stages possible in order to provide potentially a greater benefit to those patients. Despite the fact that the NLST data was published back in 2011, and we are now 10 years into this, the disappointing reality is that the most recent data from the American Lung Association revealed that only 5 to 6% of patients who are actually eligible for lung cancer screening get screened. So there is still a tremendous need out there. However, with a motivated program and with motivated care providers, then the hope is that we can increase that screening and increase that knowledge and availability to patients who may derive a benefit from lung cancer screening.
So that's exactly what lung cancer screening is supposed to be about, because historically, 80% of patients were diagnosed with stage 3 or stage 4 cancer, versus in lung cancer screening in the NLST, it was 60-some, and in our program, it's 70-some diagnosed in early stage. So now you're talking about people that you can have curative intent with when you're treating them.
Look for other episodes from TOPS that highlight practical perspectives in managing lung cancer.